So in our talk about the distal radius fractures, we will start with an introduction. So distal radius fractures are common fractures that affect the distal radius, and they occur when a significant force is applied to the distal radius, and this usually results from a fall on the outstretched hand, and they can also result from high energy injuries and sports injuries. Now, these fractures have bimodal distribution in elderly females from the low energy injuries like the falls on the outstretched hand, and in young males from high energy injuries and sports injuries. And distal radius fractures treatment include non-operative and operative methods that will be explained later in this video. Now, to really understand the distal radius fractures, first we have to understand the anatomy of the distal radius. So the radial shaft enlarges as it moves distally, and that is opposite to the ulna. So as you can see in those pictures here, so the left one is for the anterior view of the distal radius, and the right one is for the medial view of the distal radius. And we can see that the radial shaft enlarges as it moves distally, and it is opposite to the ulna because the ulna becomes smaller as it moves distally. And the distal end of the radius has 4 different sides. Its medial side forms a concavity, which is the ulnar notch that accommodate the ulnar head. So on the medial view of the distal radius, we can see the ulnar notch here. This is where the ulnar head sits. Now we also have the lateral side of the distal radius, and that forms a ridge that terminates in the radial styloid process, which is larger than the ulnar styloid process. So as we can see on the anterior view of the distal radius, we can see that the lateral side forms the radial styloid process. And the posterior side, we have the dorsal tubercle of the radius, which lies between the shallow grooves for the passage of the tendons of the forearm muscles. And on this picture here, we have the posterior view of the distal radius, and here we can see the dorsal tubercle of the distal radius, and on the sides of the distal tubercle, meaning on this side here and on this side here, we have tendons that pass, and those tendons are for the forearm muscles. Now let's move on to talk about the classification of the distal radius fractures. So the distal radius fractures are classified according to the fracture type, the location of the fracture, the displacement, and the joint involvement, and the associated injuries using radiological assessment. So when you face a distal radius fracture radiograph, you have to comment on all of these. Now, eponym names were given to the common fractures types of the distal radius, and examples for those include the Colles fracture, the Smith's fracture, and etc. But it is more important to comment on the fracture type, the location, the displacement, and etc. And then you mention the eponyms, because the eponyms are quite confusing, and it is better to comment on the fracture type, the location, the displacement, etc. first, and then you mention the eponyms. Now, although there are approximately 15 different classification systems like the Frykman, the AO, and etc. for the distal radius fractures, but none appear to be clinically useful. Most use for this fracture classification is for the research, and it is not very useful clinically. So the normal radiological description, which is the fracture type, the location, the displacement, etc., and the eponyms are used more to describe these fractures in the clinical settings. Now, there are multiple factors that increase the severity of the distal radius fractures, and those you should look for, and they include the oblique, the spiral, and comminuted distal radius fractures. So if you have any of these, means it's a more severe distal radius fracture. Also, the intra-articular fractures are more severe, and if there is significant displacement, also distal radius fracture is more severe when there is associated fractures, like an associated distal ulnar fracture, or an associated ulnar styloid fracture, or an associated scaphoid fracture. Associated dislocations increase the severity, like the distal radio-ulnar joint dislocation. Also, associated ligamentous injury, like the scapho-lunate dissociation, also increase the severity of the distal radius fractures. Now let's talk about the famous eponyms that are used to describe some types of the distal radius fractures, and let's start with the Colles fracture. So the Colles fracture is an extra-articular fracture of the distal radius with dorsal displacement, and it is one of the most common fractures to affect the human body. And Colles fracture mainly affect the elderly patients after falling on the outstretched hand, and an associated ulnar styloid fracture is present in 50% of all Colles fracture cases. Now, on the right here, we have an example for a Colles fracture, and these pictures show a wrist radiographs. So on the left, we have an AP wrist radiograph, and on the right, we have a lateral wrist radiograph. So on the AP, we can see that we have a fracture here. It's a distal radius fracture, but on the lateral, we can appreciate the displacement. So we can see that the distal fragment, which is this, is displaced to this side. And when we deal with the wrist radiographs, this side is considered dorsal, and the side where the thumb is the volar side. So this is a distal radius fracture here with dorsal displacement. It is displaced to the dorsal side, and it's an extra-articular, and all of this goes with the Colles fracture. So this is a Colles fracture of the distal radius. Also, on this X-ray, we can see that we have an ulnar styloid fracture right here. So this means that we have a Colles fracture with associated ulnar styloid fracture. The other eponym that we have is the Smith fracture, and the Smith fracture is an oblique or a transverse extra-articular fracture of the distal radius with volar displacement. So it is the same as Colles, but it's volary displaced. And the Smith fracture is inherently unstable fracture and require surgical treatment. Now we have an example for the Smith fracture here. So on the left we have a lateral wrist radiograph, and on the right we have an AP wrist radiograph. So on the AP we can see that we have a distal radius fracture right here. It is extra-articular, and it is associated with ulnar styloid fracture that we can see right here. On the lateral, we can see that we have the fracture here, and we also can see that the distal fragment is displaced to this side. And this side is the volar side, that's where the thumb is, and the other side is the dorsal side. So this is a volary displaced distal radius fracture, means it's a Smith fracture with ulnar styloid fracture. The third eponym that we have is the Barton Fracture, and this is an oblique intra-articular fracture of the distal radius with dorsal displacement, which is called the dorsal Bartons, or it can be volarly displaced, and in that case, it is called the volar Bartons. And this is an inherently unstable fracture requiring operative treatment, and it is associated with dislocation or subluxation of the radiocarpal joint, meaning it is associated with a dislocation or subluxation of the wrist joint. Now, on this example here, we have a lateral wrist radiograph showing a fracture that extends to the articular surface, meaning this is a Barton's fracture. And since we have the thumb on this side and the fracture is displaced to this side, meaning this is a volary displaced Barton's fracture, meaning this is a volar Barton's fracture. Now we can see the CT scan 3D reconstruction of the fracture here. So we can see that it's a fracture that extends to the articular surface and it is displaced volary, meaning this is a volar Barton's. Now let's talk about the other eponym, which is the Chauffeur Fracture. And the Chauffeur Fracture is an isolated intra-articular radial styloid fracture, and it is caused by loading force on the scaphoid against the radius. And this fracture resulted from the starting handle of an old car kicking back against the chauffeur's hand. And since the cars with starting handles become rare and they are hardly even any of them, this injury, the chauffeur's fracture, is become less common. Now the same mechanism may result in a scaphoid fracture. So the same mechanism of the starting handle of a car kicking back against the chauffeur's hand might give us a scaphoid fracture. Now on this example here, we have an AP wrist radiograph showing a radial styloid fracture that you can see right here. And this is an intra-articular radial styloid fracture, which is the chauffeur's fracture. This is the CT scan of the same fracture. We can see the fracture right here, and on the 3D reconstruction, we can see it more clearly right here. The other fracture we have is the Lunate Fossa fracture, and this is a fracture of the volar aspect of the lunate fossa. And the lunate fossa provides attachment for the extrinsic carpal ligaments, and displacement of this fragment may result in subluxation of the entire carpus. And this picture right here shows an AP wrist radiograph showing a lunate fossa fracture that we can see right here. So this is a lunate fossa fracture. And the final eponym that we have is the die punch fragments. And the die punch is an intra-articular fragmented fracture with displacement in form of a step or a gap, which is same what happens with the die punch machine, and that occur due to axial loading force. And a section of the articular surface is impacted below the level of adjacent cartilage, and these fractures may require delicate manipulation and fixation with levers and wires. Now let's talk about the clinical features of a patient presenting with a distal radius fracture. So the patient present tucking their wrist to their chest and supporting it with the other hand, and they complain of wrist pain. Now on physical examination, we follow the same pattern of look, feel, and move. So on looking, you look for swelling, contusions, and lacerations. and you look for deformity. The deformity may be clear, and the Colles fracture is associated with dinner fork deformity if there is significant displacement. And on this picture, we can see the dinner fork deformity of a patient with a Colles fracture with significant displacement. You also inspect the lacerations for any evidence of open fracture, and on feeling, you feel for tenderness over the forearm and over the wrist and the hand, and you do a neurovascular examination to look for nerve and vessel injury. You inquire about weakness, numbness, paresthesia, and motor examination. And on move, the patient refuses movement because of pain, and examination is repeated multiple times to exclude the compartment syndrome. On imaging, you order anteroposterior and lateral wrist radiographs, and those are usually enough to make the diagnosis, and the CT scan is indicated in highly comminuted fractures and for preoperative planning, and the MRI scan is helpful for detecting occult fractures and for detecting ligamentous injuries. And when describing a distal radius fractures, it is important to comment on the type of the fracture, the location of the fracture, if there is any displacement, or if there is joint involvement, and the associated fractures. So on this example here, we have an AP and a lateral radiographs of the wrist showing a transverse fracture in the distal radius, and the displacement is dorsal. So there is dorsal displacement, and there is no joint involvement, and there is an associated fracture in form of ulnar styloid fracture right here. Now let's talk about the treatment. So we have two options. We have non-operative treatment and operative treatment. Regarding the non-operative treatment, so most of the distal radius fractures are treated non-operatively, and the minimally displaced or the non-displaced fractures are immobilized with a cast for 4 to 6 weeks or a splint and supported with a sling, and the rest will be slightly flexed with ulnar deviation inside the cast. And fractures with significant displacement will require close reduction through traction and manipulation, and then immobilization with a cast is done for 4 to 6 weeks. Now the neurovascular examination is done again after the application of the cast to make sure no further injuries occurred during the reduction or during the cast application, and the X-ray radiographs are ordered again after the application of the cast to make sure the reduction is good. The X-ray radiographs are reordered again after 2 weeks to make sure no further displacement occurred, because these fractures tend to redisplace. And exercises are started as soon as pain allows to prevent stiffness. Regarding the operative treatment, and the operative treatment is done through percutaneous wires or open reduction, internal fixation with plating or intramedullary nails. And the indications for operative treatment include comminuted fractures, unstable fractures. So those are the fractures that redisplace after reduction. Those are considered unstable. And the fractures with volar displacement, meaning all Smith's fractures and volar Barton's fractures are considered unstable, thus require operative treatment. Operative treatment indications also include intra-articular fractures with more than 2 millimeters of displacement, and it also includes open fractures and unreducible fractures and the die punch fractures. Finally, let's talk about the complications. So the complications of the distal radius fractures include early and late complications. In the early complications, we have the vascular injury. Those include injury to the ulnar or radial arteries that require urgent intervention. In the early complications, we also have nerve injury, and the median nerve is the most common nerve to be damaged during the distal radius fractures, and it can be damaged during the injury or during the operative treatment. And if the symptoms are mild, this might be resolved with release of the dressing and elevation, but if the symptoms are severe, then this suggests acute carpal tunnel syndrome, which require urgent intervention through dividing the transverse ligament. In the early complications, we also have redisplacement. Redisplacement occurs because these fractures tend to redisplace, and that is why the X-rays are ordered again after 1 to 2 weeks after immobilization. Also, in the early complications, we have compartment syndrome. Compartment syndrome occurs when the pressure inside the muscle compartments increases due to the injury to these muscles, and when the pressure increases, the blood supply gets impaired, and this will result in muscle necrosis and eventually amputation of the limb. That is why the neurovascular examination is repeated multiple times, especially in high-energy injuries, to exclude compartment syndrome. In the complications, we also have extensor pollicis longus tendon rupture, and we also have circulatory problems due to the finger's venous circulation not draining well, leading to finger cyanosis, and that is why fingers must be checked regularly, and elevation of the fingers and finger movement is done to prevent that. In the late complications, we have malunion. Malunion is the fracture uniting at abnormal anatomical position, and we also have post-traumatic carpal tunnel syndrome, and we have secondary osteoarthritis, especially in patients with intra-articular involvement of the fracture. And in the late complications, we also have complex regional pain syndrome. This is common after the distal radius fractures, and the complex regional pain syndrome lead to swelling and tenderness of the finger joints, and also lead to vasomotor changes such as altered sweating. And with that, we reached the end of this video. Thank you guys for watching. Please give us a like and comment your ideas and questions. And this video is a part of a bigger class. It's called the Wrist and Hand Trauma Masterclass. Check it out, link will be in the description of this video. Also, the lecture notes are available in the second link in the video description.